Hi, my name is Katja Weisel. I'm Associate Professor at the University Medical Center of Hamburg-Eppendorf in Germany, and I'm here with Francesca.
My name is Francesca Gay. I work as a consultant in the University Hospital in Turin and with the EMN Group for Clinical Studies and Trials.
And we're both here at the International Myeloma Week, headed by the International Myeloma Working Group in Boston, and would like to share with you a bit the highlights of the today's session. So, Francesca, what do you think? We saw today a lot about newly diagnosed myeloma. I think we haven't seen so much news about relapsed myeloma, so I think we start with the newly diagnosed one, and there was one trial again, at the front, and this was, from my opinion, Cassiopeia. What would you mean?
Well, Cassiopeia Trial is a very big study that showed the benefit of adding daratumumab to one of the standards, that is VTD, in the setting of transplant. So the data that have been presented today show the high efficacy of this regimen in the setting of high-risk patients. And the other point showed that there was a good concordance in the rate of minimal residual disease negativity evaluated by both next generation flow and next generation sequencing. So these are two good messages from these big trials that to me are quite important. On the other hand, we have seen this today also how to try to improve from a patient and clinician perspective also on the feasibility of the drug administration, and we have had a presentation on the use of daratumumab sub-Q with the different combination. Would you comment on that?
Yeah, I think this is from, as you said, a patient's perspective, a very important point that we now will receive the antibody formulations also sub-Q, what we know from the lymphoma treatment with the rituximab or even for breast cancer treatment. And RHI showed the data on daratumumab sub-Q. It was combined to the standard of care regimens already tested with DARA, so VRD, VMP, RD, and it's very convenient. It's a flat dose, and it can be injected sub-Q in between 5 minutes. And obviously, what is very impressive, that patients seem to have no real local reaction or very few, and that you, in the daily clinical routine, get kind of nearly completely rid of the infusion-related reactions. So I think from the patients and also from the resources perspective, this is a very nice approach we can, I think, rapidly introduce into the daily routine if it will be available. So I personally had some experience in clinical trials, and I also think it's a really convenient application mode. What I always think when we face the very good Cassiopeia data, that the thalidomide might be the drug probably which is in any sense a bit like old-fashioned and probably not the optimal in this setting. You mentioned that we saw today's group analysis of especially high-risk patients, and what we did in the cooperative group is to put the next generation of the drugs together. We have a trial, and I presented today the safety run-in phase using the monoclonal antibody isatuximab, also against CD38, and then the more potent proteasome inhibitor carfilzomib together with lenalidomide and dexamethasone, and in high-risk newly diagnosed patients. And we reported about the first 10 patients. This was the safety run-in phase, and we were very pleased that we saw no toxicity signal, that we had a very good tolerability. And in the first glimpse on the data, we also saw that all patients responded with at least a VGPR. So I think this might be the direction to go, especially for high-risk patients, that we have tolerable but very effective regimens allowing us to achieve MRD negative disease.
Yeah, I think this is very important because high-risk patients are an unmet medical need. We have talked a lot during the meeting about how to treat and how to approach these patients. And two points that have been underlined several times are that you need to treat them appropriately with the treatment that is able to induce a high quality response and the minimal residual disease negativity, and also the role of minimal residual disease negativity in the setting of high risk have been highlighted in this meeting as in other meetings. So having efficacious treatment that are basically quadruplet of monoclonal antibodies, PIs, and immunomodulatory agents up front for these patients and able to induce a high quality remission, it's really important. I have a question for your trial. I think it's also a model of how you can learn from what happened to the patients. So you saw at the beginning maybe an initial impairment in the possibility to collect a stem cell, which is in line probably also with the Cassiopeia trial, where there is quite a high number of patients who used the plerixafor for stem cell mobilization. So, and if I understood correctly, you changed a bit your way of, the time point where you decided to collect stem cell. Would you comment on that too?
Yes, in fact, we saw in the first patients that even some patients, despite the use of plerixafor, failed to collect stem cells, and so we reacted on that and moved the stem cell collection more in front. I personally think that the combination of the anti-CD38 antibody and the immunomodulating agent is somehow hampering the stem cell collection. We knew from the early VRD experience that it was more difficult to collect stem cells than with the cyclophosphamide-based triplets. And now it seems that CD38, and we know that it's expressed on hematopoietic progenitor cells, the anti-CD38 strategy might again make it a bit more difficult. So in fact, now when moving the stem cell collection more in front, we have the impression that it works better, and we will hopefully present that data next year when we have enough patients to compare. I would like to go back again to the Cassiopeia trial and would like to ask you for your opinion on the MRD analysis. That was the question, what is better, flow or NGS? And Hervé Villouzou did not really open his opinion. He said he thinks both it's kind of equal or exchangeable. From your personal experience and your view, what do you think? Will we use in the future more flow or more NGS?
Well, it's a difficult question, and I don't think there is an answer. Hervé is an expert on MRD. So I think that there are some points in favor for NGF and some other in favor for NGS. We have NGS is an approved FDA test so far, so this is of course an advantage. NGF, on the other hand, when standardized, can get to the 10 to the minus 6 sensitivity. It's really important to have the right labs. NGF need to be done with the fresh sample, so you need to do it immediately. With NGS, you can have the advantage to use also frozen samples. So there are pros and cons. I think that at present, we cannot say one technique is clearly better than the other, and in fact, in the IMWG criteria for the definition of response and of minimal residual disease negativity. Both the techniques are considered two available techniques. To me, the key points are in which patient should we definitely perform them, because there was a long discussion if we have to perform the MRD in patients that are VGPR negative, that achieve the VGPR, or only in patients with CR, which again, in terms of concordance and can make a difference. But there's a huge work in progress, and I think that in a few time we will be able to answer to this question.
So probably we will have the discussion again in 2 years when we meet in Vienna.
Yeah, exactly.